now the question is, where are the valves of the inflow tract? If you remember, the first valves, which had a certain clinical importance, were Philip Bonhoeffer's melody valve, and 2 years later, the aortic valve followed. Now, where are the mitral valves? Where are the tricuspid valves? They do not yet still exist. Well, we heard Mario talk about the pulmonary valves, and the melody valve was made for a location where the surgeon already did something. In this case, he prepared the outflow tract with a heavily calcified homograft, where we now put in a valve. But what we heard as well is that we can put a melody valve as well in a bioprosthesis, like in this case. And of course, now the intellectual step is only a micrometer to say, okay, if there's a bioprosthesis in tricuspid position, why shouldn't we start to put in this valve only a few centimeters in front of the pulmonary valve in tricuspid position? And indeed, that we did, and that works as well. So this is almost the whole story. Yeah, that's it. And you see the result is as good as in pulmonary position. Well, is there anything which we should mention perhaps? Well, yes, we can say even in tricuspid position, we are happy to have a bioprosthesis as a landmark. The access is even easier than in pulmonary artery because we only have to come up the IVC or the SVC, and we have plenty of time. We can go and have a coffee, and then we implant this valve. You see how much time it takes. And we take this time because the valve is relatively short, the landing zone is relatively short, and of course we want to give it, implant it in the exact right position. And if you have a look now, then you say, well, is it really so easy? Because normally we would like to adapt it to the ring of the bioprosthesis, our transcatheter valve. So should we move, should we do something that this really fits together in an ideal way? And yes, we should do something. We just go on, because luckily this bioprosthesis will tilt in the last moment when the balloon is inflated, and then it comes up to a good result. Now, so it is even easier to implant this valve into the tricuspid position than into the pulmonary position. And others around the world had the same micrometer intellectual step, and in 2011, Philip Roberts sampled around the world cases, and these are the first 15 cases published so far with good results. And there was an editorial comment to this publication, Transcatheter valve technology, a game changer. And indeed, that it is. It influences our clinical thinking enormously to see whether there are other possibilities, other strategies, even for the surgeons, to get these transcatheter valves placed in the future. Now, when you deal with new valves and you put in the inflow tract valves, then of course you have to deal with a lot of different valves, and often you have no idea what sort of valve, which size of valve, and how to deal with it. Well, and in the modern world, of course, you have apps, and this is the app Valve in Valve, which you can get for free, and where you can search either in aortic position or in mitral position with this menu. Well, if you know the valve, this is an advantage, but even if you don't know the valve, you can try to identify with this tool the valve.
Do you know where this app was developed?
By
who?
Pardon?
By who?
By who?
Yeah.
No, I don't know.
It's a surgeon called Bapat from St. Thomas's Hospital in our unit.
Oh, well.
So, and it is free, so use it.
Okay. So I didn't find his telephone number, because otherwise I...
Actually, he's not that intelligent. It was his daughter, who was a 16...
I see. Okay, yeah. That makes sense.
16-year-old who developed it.
Okay. Yeah, because it's an app. It's too modern for... Yeah, okay. Well, this is a helpful tool, and you can recognize almost every type of valve which is implemented here by the fluoroscopic view or by other types, perhaps by the surgical records. You never know. However, the problem is, even if you have the data available, of course, you would not rely on this because, over the years, these valves can change. So we perform, in every case, a balloon sizing. And this we did here in a case we performed in Lyon. There was a diameter larger than 27 millimeters. And it was the time where the sapien valve was not available yet. So what we had to do is we had to downsize this diameter, and we used this technique where we put in 2 stents simultaneously on a large balloon. This is a laser cut stent with a very tiny framework and a CP stent put over one over the other, and then you get this hourglass shape. And after some pre-stenting of this large biological valve, you then get a good base for the putting in. This is with just before lunch. These are the problems you have to deal with then. To put in a melody valve on a 24 millimeter balloon, and the result was very good. Now, are there other indications for valves in the tricuspid position? This was the echo, and you see even with a 24 millimeter balloon, the result is quite nice. The red color from the color Doppler shows a certain accelerated flow, however no stenotic flow, and you see a minimal regurgitation. Now, this is another patient where you had a very smooth sizing balloon, and you got a distance of 24 millimeter inner diameter, but this was formed by these hinge points for the valve, and we were not sure that we really could rely on it, so we repeated the sizing with a 30 millimeter balloon, and there you see 30 millimeter is easily achievable, and you need a large valve. However, as Mario pointed out, we have this 29 millimeter sapien valve. However, the thing with this 29 millimeter valve is it is made for aortic position. It is not intended to use on the pulmonary position. And the trick with this valve is that you assemble the valve inside the body. So you have the balloon, you have the valve, and inside to have a very narrow introducer sheath, you slip the valve over the balloon inside the body. And if you do this for the aortic position, then you push the valve back on the balloon, while when you put it in the pulmonary position, integrate, then you have to push the valve against the leaflets, if you understand. And up to now, this doesn't seem to be a problem. But this is, of course, off-label use. It works, and it is performed. Now, special situations are Björk-Fontanes, where you have a connection between the right atrium and the right ventricular outflow tract, either by a large patch or by a homograft. Well, we had a patient with a homograft where calcified, where we then put in a valve in this position, and the result from the pressure recordings here, right ventricular pressure pre and post intervention, you see what a marked anterior flow and how a marked increase in pressure this right ventricle was able to perform after a functioning valve. This is a patient where an outflow tract patch is. Is there a pointer somewhere? Or does it work with a, here we are. Where an outflow tract patch is implanted to open up this membranous disconnection between right ventricle and right atrium. And if you have a sagittal view, you see the connection is a large oval communication. And in this case, when we balloon-sized it, there was no chance to put in a valve because it was too large and there was no rigidity where we could implant a valve. The good thing, which was useless in this case, but is that the right coronary artery is far away and would not have been compromised. Well, of course, you can add a tricuspid valve implantation to a pulmonary valve implantation that amplifies your possibilities, and you could take this into consideration. Now, our current Munich-Berlin experience are 16 valves implanted, mostly in adults, half melody, half sapien valves. The follow-up is up to 4 years. Now, is that the whole story? Interestingly, it is not, because there are 2 other aspects. First of all these tricuspid valves implanted are no tricuspid valves. and therefore there's no reimbursement. So whenever you try to implant this valve for the sake of the patient, you have to reconsider how to finance it, and you always have to have communication with the insurance company for any case so that you get your money back. And the second one is, there are a few cases published where after a really short time of several weeks, these valves get regurgitant. And this is such a case. After 2 weeks, there's severe valve dysfunction. This is a transthoracic echo, and you see there is a regurg and a turbulent inflow, which significates stenotic area as well. And this is the publication to this. You see there's Andreas Eichen from our center, Jacques Qureshi, I think he comes from Britain or somewhere, and John Thompson from Leeds. And these are 4 cases where this happened. And interestingly, in 2 of those patients, the valve was explanted. And more interestingly, this was one of the Leeds, in Leeds explanted valve, as far as I know. And what you see here is a native melody valve, and this is one of these explanted valves. A completely, well, in its function, destroyed leaflet. They are, I don't know how it's called, crumpled or something like that, and they shrunk, and they are thickened. They can't close, and they do not open. So there are some tissue reactions going on. However, in a valve which we explanted in Munich, the situation was this. The leaflets are almost as untouched as they were when they came out of the package. And in these histologic cuts, you really see that these valves are unaffected. And so probably there are 2 mechanisms for this valve dysfunction in tricuspid position. One might be that there is some immunization or other things going on where the body really recognized these valves as foreign bodies. However, it's interesting that that was not in this way described in the pulmonary position. And the other one might be that there is perhaps some mechanical difficulty, that perhaps the rise in the pressure rise during contraction of the right ventricle in a poor contractile right ventricle perhaps is not enough to get the valve closed. And perhaps these both components might play a role. Now, there's another inflow tract valve, the mitral valve. I only want to show some pictures. Of course, the melody valve has found his way transcatheter by the veins through transeptal puncture into a mitral valve position with good function in a series from Boston. This was published. This is, of course, not a routine use, but it's feasible. And more interestingly is that this is possible not only in valves, so as a valve-in-valve procedure, but also in mitral rings. And even more interestingly is this is a series where this was made in animals in different type of rings. This is a complete mitral ring. This is only half a mitral ring. This is a saddle-shaped mitral ring. And in all these shapes, melody implantation is feasible and got a good result. And I think the issue why this isn't performed so often is that, of course, people who, well, these are mostly elderly people with acquired heart disease, and they are in the hands of the surgeons and the adult cardiologists, and they are much more prone to get transapical approach to the mitral valve replacement, which is performed by the surgeons relatively often. I think we could play a larger role in those kinds of patients. Now, and the last thing is an idea which Philip Bonhoeffer had relatively shortly after the introduction of the melody valve, to put an AV valve in a native, in a transcatheter valve in a native valve. I think he was a little bit ahead of his time, as usual, and this was not developed in a strategic way. But here is another idea how this could function. These are springs of self-expanding scaffold where the valve is in, and in an animal experiment is shown how this could then look like. So you see here the springs from the ventricular side, they go up to the aortic valve, and they catch the papillary muscles, and from the atrial side there are shorter springs which secure the valve on the atrial side. So I think this is an interesting development which sooner or later will enhance our possibilities. Thank you very much.